All right. Good morning. I just want to welcome all of you and also want to welcome all the people watching online. The lecture is being streamed to a lot of people, especially the people attending the Institute for Global Public Health event. I just want to start by acknowledging that the University of Manitoba campuses are located on the regional lands of Anishinaabe, Ininiwak, Anishinaabe, Dakota Oyet, and Dene, and on the national homeland of the Red River Métis. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with indigenous communities in a spirit of reconciliation and collaboration. The Rady Faculty of Health Sciences is doing a lot. We are actually a trailblazer in the University of Manitoba in really putting into reconciliation, the act of reconciliation, in a positive way. Myself, I'm a first generation immigrant from Africa, also who was colonized. Even though my experiences were not the same as that of the indigenous, I think we do have some similarities. But I dedicate myself to trying to learn to understand what the indigenous people have gone through, so I can actually work in my own capacity to really work with them and reconcile with them, which I'm truly grateful for them to have me here. So I want to welcome you all to the lecture today, the Henry G. Friesen lecture. I'm glad Dr. Friesen is here. Nice to have you. This lecture is named after him. In health, it was really established in the, just to honor the exceptional leadership, vision, and innovation and contributions of Dr. Henry G. Friesen. Many of you don't know about MRC. I think you all only know about CIHR. But before CIHR, there was MRC, Medical Research Council, and Henry was the leader of MRC and actually worked towards transitioning MRC to CIHR. And he has done a lot to contribute to research landscape in Canada and also in Manitoba in particular. The award is awarded to an individual of international stature who best exemplifies Dr. Friesen's pre-science, organizational creativity, and broad impact on health research and health research policy. The award includes a visit and scholarly event at Canadian universities like we're having today. The prize and related events are organized by Friends of CIHR, which is a national not-for-profit organization that was established in 2000 to support the goals and ideas of the Canadian Institute for Health Research and to communicate the values of science to the entire public. Through a spectrum of programs, Friends of CIHR also seek to attract and support young health science trainees and scientists in their careers. It's my pleasure to introduce Dr. Peter Lewis, who is the interim president of Friends of CIHR. He will introduce the Friesen laureate today. Dr. Lewis is a professor emeritus of biochemistry at the University of Toronto and the board chair of the Charles H. Best Foundation. He has also held several leadership positions, including department chair, vice dean research, and as well as also associate vice president, global and research partnership at University of Toronto. His research interests include Alzheimer's disease, the structure and function of chromosomes with specific reference to gene regulation, protein folding, and the application of artificial intelligence in drug discovery. I think it's through this type of research that I can see Jim here sitting down in the audience that it could be a very long-term interest together. So please join me in welcoming him to introduce the laureate.
So thank you, Professor Uzona. I want to thank you and the University of Manitoba on behalf of the Friends of CIHR for hosting the 2023 Friesen Prize program and to honor Professor Zulfiqar Bhutta, who you're going to hear from today. The Friesen Prize, as you've heard, and related events today are organized by our organization called the Friends of CIHR, which is a national organization focused on the support of health science in society. FCIHR advocates on behalf of young people and as career scientists and encourages the funding of health research in Canada. We are supportive of the goals and ideals of CIHR and are eager to recruit young people to our activities across the country. As you've heard, this year we're honoring Professor Zulfiqar Bhutta, the 17th Henry G. Friesen Prize winner, who was selected for his, as you'll hear, exceptional contributions to the health and development of children around the world. As he mentioned, we're very fortunate to have Dr. Henry Friesen, for which the prize was established in 2005 in his honor for today's events. So in addition to the events here in Winnipeg today, Dr. Bhutta has had a whirlwind tour through Ottawa University, University of Toronto, the Global Health Day at McGill University in the fall, and then visits to Waterloo University in January, McMaster University in February, and the University of Calgary last month. Today, as you heard, we celebrate the 2023 Friesen Prize awardee, and we're very grateful to Dr. Bhutta for accepting the obligations inherent with this prize. A brief biography of Dr. Bhutta is provided in the announcement you would have received, so I won't take more time away from his lecture, but I will highlight that through his long career, he has made innumerable seminal contributions to improving the lives of millions of people, both in Canada and around the world, for his life-saving work in the first 1,000 days of infants with respect to maternal child health initiatives related to nutrition, infection control, and public health. At least as importantly, we got to know Dr. Bhutta better during his tour of Ottawa and recognized him as a humble, compassionate man with insatiable scientific curiosity. At the same time, during meetings with officials at Health Canada, including the Assistant Deputy Minister, we witnessed Dr. Bhutta's passionate and compelling advocacy for the urgent need for federal investments in Canadian science and scientists, both now and for the future generations. So he is an inspiring, as you'll see, and visionary scientist, clinician, and teacher. So we look forward to your lecture, Dr. Bhutta.
Thank you very much, Peter, Friends of CIHR, Dr. Friesen, for the opportunity to speak to you today. Yes, indeed, this has been a whirlwind opportunity to go to many Canadian centers. But in addition to center leaders, to particularly meet young people, people who are the future, and those who really aspire to see a world which is better than what we find it today. And that's basically what drives me in global health. So I picked this specific topic today of looking at something which is an existential crisis for the world. And there is not a single country in the world that's not affected. There may be differentials in terms of who's impacted, and my own work is particularly focused on low and middle income countries. But if there is one thing that unites us today in terms of trying to do something about this planetary crisis, it is the crisis of climate change. So what I hope to do over the next 40 minutes or so is to cover basically the overall evidence of the relationship of climate change to particularly women and children health globally, especially focusing on low and middle income countries. I'll talk a little bit about what we know about the epidemiology, some of the risk factors and drivers on areas that have not hitherto been a big focus of global attention and research. And I'll talk about solutions, both in the context of what we know from evidence and also from some of our recent work in Pakistan. Remember, in a lot of this, the work is only just beginning. And one of the reasons why this is so important is that we need far more attention in this space than what we are getting. So to this particular audience, as well as colleagues who are assembled in the Global Health Conference at Fort Garry, this slide is not something that will draw negative reactions. But I can tell you that I've spoken on this subject over the last 6-7 years, where there have always been naysayers in the audience to say, we don't quite believe that this is really an exponential increase in global warming over the last several decades, that this has been going on for a long time. But if you look at the confluence of where the models told us we would go, simulation, and actually what has been observed, things are much worse than what people had predicted. And we are actually going to reach many of the thresholds that have been established for global warming much faster than we had. Last year was the hottest year on record from every angle, from records that were largely kept in high-income settings to world meteorological data, and also importantly from the impact that it had on low and middle-income countries. And if people thought that last year was an anomaly, all you have to do is to see the figures from the first half of this year. The first quarter of 2024 saw heat waves in North Africa that were unprecedented. Temperatures on average exceeding 45 degrees centigrade for weeks on end across the entire Sahel and North Africa. And just this month, just last week at the Hajj, for the first time in living memory, more than 1,300 people died because of heat exposure and strokes, despite all the effort that's put in place for addressing health needs of the population. So this is not something that we can avoid anymore because the evidence is right in front of us. A few people equate climate change with just broad global warming, but there are also changes in precipitation that come alongside, and changes in rainfall patterns and other risks that are equally important. And they're sometimes working in tandem with the heat impacts to generate many of the crises that we see alongside. And they're happening in atypical environments. So just a few months ago, Brazil. I don't know if is there anyone from Brazil in the audience, but southern parts of Brazil had unprecedented floods. Millions of people were affected, and close to around 1,000 people actually died in those floods. Again, unrecognized. In one of the poorest parts of the world, which is actually landlocked, Afghanistan, we witnessed effects of floods that had not been seen in a generation. So these things are coming together. And in my own country of birth and origin, we witnessed this a couple of years ago. So in 2022, August, we had, following an extreme heat wave in southern Asia, parts of India, parts of Pakistan, with average temperatures exceeding 40-45 degrees centigrade for weeks, we also saw something that we hadn't seen before. We saw a change in the direction of the monsoons. The monsoons typically come into that part of South Asia, Pakistan, from the north. This time around, the monsoons entered Pakistan from the south, which caught everybody unawares. And as a result, we had almost biblical floods. Over 30 million people were impacted. And of the people who died in the first 2 weeks, roughly about a third were children. The floods themselves followed in the wake of COVID-19. And a lot of the economic downturn that many countries in the world witnessed, Pakistan was also subjected to economic downturn. But the floods were the straw that broke the camel's back because it caused a net loss of over $35 billion. And the economy has just not recovered from it. So this compilation, a year after the floods, which has now been expanded to 2 years after the floods, tells you very clearly that the world is distracted. External assistance for a loss of $30 billion basically has been less than $2 billion. And you can well imagine in a country with a net debt indebtedness of $60 billion, adding a $30 billion loss on top of that gives you the sense of the polycrises that many countries are facing in the context of climate change. And that's the point I want to drive home, that it's not just climate change alone. Climate change in many countries is a threat multiplier. It exacerbates the impact of political and economic instability. And we are witnessing this in many places where extreme poverty is closely linked with climate change, as is conflict. Now, the way I can tell you how important this is just by showing you the overlapping geographies that are facing these polycrises. So this is the world of climate change vulnerability. All the dark-colored regions are the regions which are extremely vulnerable to climate change, and not a big surprise, they are South Asia and parts of Africa, both North and Sub-Saharan Africa. If I was to superimpose on this the map of where current conflict is concentrated, it's almost the same geographies of parts of Africa. You'll throw in a little bit of Middle East and some regions of South Asia. Add to it the risk of pandemics and relative vulnerability to outbreaks. And you see that some of these geographies are also the weakest parts of the health system. And then you look at the net impact post-COVID, post-Ukraine on global economics, and you see that absolutely these are the geographies which also don't have the mechanism. So the point that I'm trying to draw home is that climate change is increasingly being seen in the context of these polycrises, exhibited as the 4 Cs here. And the regions of the world that are impacted by these polycrises are also least equipped to deal with it on their own, without diversion of resources. Some 40% of the global mortality of children, the close to around 3.5 to 4 million children who die every year, are concentrated in these geographies. It just tells you how important this is in the context of global challenges. Let's explore for a moment what are the interconnections of climate change and health outcomes, especially with a focus on maternal-child health and nutrition outcomes. This particular graphic tells you how, for example, the various manifestations of climate change, whether they are rising temperatures, whether they are disasters, environmental change, how they are linked to factors that increase the impact of infectious diseases, also common childhood illnesses, malnutrition, non-communicable diseases, and so on and so forth. What people don't recognize often is that climate change impacts health outcomes through a variety of pathways and cascades. And it's important to recognize that the direct effects of climate change are compounded by the indirect effects of climate change. And they, in turn, really very much depend upon what I call the social determinants, the social dynamics of drivers which exist in a particular environment that completely modify the impacts of climate on subsections of the population. What do I mean by this? So if you already have persistent inequity, if you already have rampant poverty, and as I've already mentioned, if you have drivers and dynamics such as gender-based inequities, then the impacts of climate change are a lot more exaggerated in those populations because they work through pre-existent conditions. In the context of the impact of climate change on nutrition, for example, exclusively the focus so far has been on the food chain, has been the impact of climate on agriculture, on food production, on the food systems, on transportation, preservation, and all the farm to market pathway. Relatively little has been done in terms of exploring other impacts of climate on human nutrition, particularly nutrition of women and children. So some of the impacts are pretty clear, and you don't have to go to lower middle income countries to find those impacts. For example, we know from studies in high income settings, this is a particular graphic from studies in California, that with increasing heat, you have a reduction in agriculture production, unless you have climate resilient agriculture. And most of the climate resilient agriculture does still not reach the productivity levels in normal populations. We also know that heat also impacts the content of crops, particularly micronutrient concentrations of crops. In this particular graphic, you have C3 crops, which are grains. And almost all of these grains, once exposed to heat, you have a reduction in key micronutrients like zinc and iron. But these impacts are those that are on the food chain and on the higher level impacts that we see of climate on agriculture. What about the human consequences of exposure to heat and climate? Now we believe now, with data and evidence that's available, that some of these adverse effects are actually direct on pregnancy, on mothers, and particularly the vulnerable populations. And many of them start much before childbirth, and may actually, even from the biological evidence, be starting preconceptionally, just because of exposure impacts. Now, what is the evidence that this is something that we are encountering both in pregnancy and in early infancy? The animal literature tells us a lot, because there has been work in the One Health scenario of the exposure of various animals, largely dairy animals and others, to heat at different stages of life and pregnancy. And what that tells us is that the mechanisms of heat may impact pregnancies differently at different stages. Obviously, if you get exposures to extreme heat, environmental factors, very early in pregnancy, then you see impacts which are largely related to pregnancy outcomes, which include things like stillbirths, malformations, and others that have been seen in those particular contexts. But there's also evidence emerging that later exposure in pregnancy could actually impact the duration of pregnancy. So we now have enough epidemiological evidence to indicate that maybe the duration of gestation, prematurity, could be related to exposures later on in pregnancy. Much of the epidemiological evidence of this relationship to adverse outcomes comes from high-income settings, because there has been relatively little work on this in low and middle-income countries, and most of the work is available has been descriptive and retrospective. This is data, this is a forest plot of the impact of extreme heat on birth outcomes. And here, this is related to prematurity rates, odds per degree increase in temperature. And across a range of these geographies, you see that exposure to high ambient temperatures increases the risk of prematurity. And a question is very legitimately asked, well, is this true in all populations? What about populations that are a bit more resilient, have a lot more exposure to hot summers than others? Is this universal? Well, it's very clear that the effects could be indeed universal. This is an analysis of heat impacts from birth cohorts in 14 low and middle income countries, largely Africa, but also including cohorts in Asia. And it tells you two things. This particular graphic shows you the impact on prematurity rates. And what it shows you is not only with an increase in temperature, there is an increased risk of preterm births, but it's not just temperature itself or maximum temperature, it's also the reduction in the diurnal variation. So if you don't have the cooling effect at night, or a change between the daytime temperature and the nighttime temperature, in other words, slower or lower diurnal variation of temperature increases the risk of adverse outcomes, in this particular case, prematurity. And in the same study, they were able to observe the similar impacts on excess risk of stillbirths. So it just tells you that these exposures at different points in time may be impacting pregnancy outcomes in different geographies, more or less broadly in the same direction. But as I pointed out, a lot depends upon your living and social conditions. And perhaps the best evidence I can give you of the impact of heat on adverse outcomes is not from a low-income setting, is from Boston. And here is a study which showed in a big cohort of around 4,500 mother-baby dyads in Boston Children's Health Watch cohort as to what happened to adverse outcomes in pregnancy related to exposures to a relative change in temperature in pregnancy. And the two sections of this graphic tell you two different stories. So it tells you the story of homeless individuals as compared to those who were within shelters. And the negative impact that you saw on adverse birth outcomes was largely restricted to the homeless population in Boston. So it's not just exposure, it's also the social circumstances. Now, no one is suggesting for a moment that homelessness was equated with relatively more exposure only. There may be other social constructs, but one has to be cognizant of this in terms of looking at the adverse effects of climate change. Perhaps the best data on this that we have is not from retrospective chance observations, is from prospective studies. And these are data from India, from a large study done in South India and recently published, which looked at 2 sequential cohorts interrupted by COVID. But it made 3 very important points. One of these was that all of what I've told you about adverse birth outcomes in relation to heat exposure were completely documented in this birth cohort, with miscarriage rates and stillbirth and prematurity rates almost 2 to 3-fold higher in the women who were exposed to extreme heat. But it was not just exposure to extreme heat. It was also the clustering of impact in women who had high occupational heat exposure. So had a combination of outdoors work and heat exposure. And this is one of the realities that we face in many low and middle income countries, because women work in agriculture. Women work in occupations and exposures where they don't have the choice in terms of restricting their activities, and social norms in many places also prohibit responses that men can have. The dress code in many places for women is fixed. So whether it is blistering heat, unlike men, they can't change their clothing patterns to suit the environment. And this is the ground reality. In my own geography, this is work done in Pakistan at the Aga Khan University by colleagues looking at data from a large intervention study looking at maternal nutrition interventions and birth outcomes. And what they were able to do, again, looking back at their data, was to look at the subset that was exposed to what they called extreme heat. And here it was just 39 degrees centigrade or more heat stress days over a period of time. And they documented 2 important things. If the heat exposure was in early pregnancy, it led to a significant reduction in linear growth as impacted by length of the baby at birth, and also, more worryingly, head circumference at birth. So these babies who were born with exposure to extreme heat in early trimester of pregnancy had also smaller heads at birth. That may be related to growth restriction in size, but it also tells you how much more we need in terms of learning a little bit more about developmental outcomes. And while they were not able to discern from their metabolomic studies any clear signals, these are the limitations of retrospective data that did not really capture many of the pathways that could have been important in terms of looking at linear growth. Hence the importance of prospective studies in this. In our own work, we've been very interested in not just the effect of acute heat exposure or extreme heat, but chronic heat exposure. And one of my own areas of work is on looking at linear growth or stunting rates in children. And I was struck by these data from Africa some years ago, which had looked at retrospective data sets saying that a 2 degrees centigrade rise in temperature would increase stunting by about 7%. This was based on modeling on existing data. And it wasn't very clear how this could happen through and what pathways would be there. So we looked at this recently in Pakistan, because my group has done 2 large national surveys sequentially over time. And we determined 2 important things. So those of you who know the country would know that there is a tremendous gradient in stunting rates between the north and the south. Here are data for maternal nutrition, and you show that there is a north to south gradient. And if you superimpose on this a map of childhood stunting and wasting, you see that it's almost homologous in terms of areas where you have this clustered. So we were able, because we had geospatial coordinates, were able to look at temperature change in the sampling frame of these 2 surveys to look at what has changed in this 10-year period in terms of average ambient temperature, but also interestingly, precipitation rates, soil water content, and a host of other things, including agriculture food production. So without boring you with all of that data, if you look at the temperature gradient, there is a clear north to south gradient with the southern districts and regions also being much warmer in the last few years than they had been in the decade preceding. So when you put all of this together in a multivariate analysis in terms of what are the predictors of linear growth, you see a number of things were in the right direction. That improved maternal nutrition, improved wealth, food security, size at birth, maternal age, all of those increased linear growth in children. This is not stunting, this is linear growth, length for age z-score. But you have a negative effect in this multivariate analysis, controlling for everything else, of environmental temperature. And interestingly, you have a negative effect also of increased precipitation, which we did not understand initially. Why should increased precipitation negatively impact growth? Well, it impacts growth through waterlogging and the impact of floods. And you see this effect not just on stunting, you also see this effect on wasting in children. So these are observations which allow us to now look at a research agenda in terms of how we need to understand the relative contribution of environment, not just water sanitation hygiene, but also temperature and humidity or wet bulb temperatures to what is happening in pregnancy and growth with potentially intergenerational consequences. And I can tell you there's not a single program globally which has as yet integrated climate mitigation and adaptation resilience within its own repertoire of interventions. So I want to step away from this and just one more thing to show you in terms of the impacts, which is on the impact on mental health and other things. And mental health is very clearly a risk factor for adverse outcomes of climate exposures, which has been documented in the literature. It is also disproportionately concentrated in the most vulnerable, women, children, elderly, those who are very poor, the ultra poor, and it is exacerbated by disasters. So when you have climate change impacts compounded by things like emergencies, floods, forest fires, then you see the mental health impact of this really coming out as a huge issue. And it is an issue for young people. In fact, I learned something new as part of my work on this in the last few years, a term that I wasn't told in medical school. And that term is called solastalgia. And for those who don't know what this means, this is basically climate anxiety in young people. And it is largely being driven by the fact that many young people, as young as school-age children, look upon this as something that's going to impact their future. And you can well understand why in the global climate drive and the global advocacy around this, why are school children in the forefront? Why are they ahead of the university students and postdocs and graduates? It's because for them, this is an existential issue. And we now have evidence of this as being a major issue across the world. So in this particular study, they looked at climate anxiety in several countries, many of them high-income countries. And the figures are shocking. I mean, but 25 to 30% of all young people expressed extreme anxiety about the future and climate. So mental health issues are really there in the forefront. Let me now switch gears and talk about solutions. What can we do as a global community, as scientists, as advocates, as pediatricians, and obstetricians in addressing this issue? And to do this, I have to clarify two concepts because I get asked this question all the time because there is confusion as to how much is mitigation and how much is everything else. So mitigation largely reflects on enterprises or activities that reduce greenhouse gas emissions, reduce the carbon footprint, and largely reflect what the world has been doing right now. And they largely reflect the work of the IPCC, which has been around reducing things at force. These are things that affect the big oil producers, guzzlers, and companies and governments. They are so far removed from the reality of low and middle income countries that it's not surprising that in the work of the COPs, and we will have COP 29, the 29th meeting of this global community of people who talk about climate change. Last year was the first time that health was on the agenda. And this year we'll see in Baku what happens. Do low and middle income countries come up to the fore? If you look at the work of the IPCC, which is the global body looking at climate change, the proportion of its reports devoted to low and middle income countries' adaptation and resilience are minuscule. And they relate that to lack of evidence. Of course, absence of evidence is not evidence of absence, right? I mean, the work out there may not be randomized controlled trials, but there is tacit knowledge in communities, including the indigenous community here in Canada, of how to look after the environment and how to adapt perhaps to environmental change a little better than others. So I'm going to talk about the strategies that need to be done around adaptation, resilience on the ground in low and middle income countries. And there are frameworks now being developed as to how these community-based approaches can be scaled up around both increasing awareness and also putting interventions in place in communities where the health systems can address this a little better. But I want to start first with issues that are outside of health. What kind of structural innovations we should be thinking about in terms of adaptation in poor communities, knowledge that has been lost over the years as we have built communities, societies that are not geared towards heat adaptation. So what are these structural innovations? So my interest in this arose from the simple observation in my country, in Karachi, which is a city with a population of about 25 million, as to what had happened in 2015. In 2015, there was a heat wave which killed around 1,500 people or thereabouts within 24 hours. People were caught completely unprepared, just like has happened at Hajj, and I'll come to Hajj in a minute. So we looked at where were these deaths clustered. And it doesn't take a rocket scientist to work out that there are only 3 or 4 areas in the city where they were clustered. And most of these were urban slum populations. So urban slum populations in these mega cities have their own dynamics. They're also heat ovens. We would not leave our pet dog or cat in a closed car, in a car park in the middle of the day. That's common sense. We know it now. Although people still do it. They leave their children in cars, right? These urban slums are no better than heat ovens. Why? Because the construction patterns have changed over time. These are congested settlements with limited ventilation, largely tin or other materials on roofs, and that superheats. So if they have no cross ventilation, you can well imagine what can happen in those environments over time. And there have been a number of innovations looking at what can we do to make these things a little better? Can we change settlements? Can we improve ventilation? Can we improve construction material? And there is some work ongoing, largely positive, on looking at things like reflective paints. Now, they can be a Rolls-Royce variety of these enamel paints, white enamel reflective paints, which are very expensive. Or you could have innovations, as have been tried elsewhere, of using slaked lime in the hands of women who are incentivized through conditional cash transfers of painting their own roofs with this slaked lime, which works. There is a reason why in Europe, in the Mediterranean region, in Spain and elsewhere, houses are painted white. Construction materials are of the kind that are reflective. And if you think about it, also, the concept of the siesta came out of the fact that you could not work productively at the time of the day when it was hot. All of those things have been lost over time. So a lot of potential in the use of construction materials and reflective paints and other things that include also green roofs and plantations in many of those settings that can help dampen some of the impact of extreme heat. And we've looked at the global evidence around what green roofing and green walls can do to internal temperatures. And to any student in the audience, if you look at the direction of travel, all of these impact ambient temperature inside the house. So there are benefits to doing things like this on a self-help basis within all these communities. And then, of course, innovative people like architects. This is Yasmin Lari, again from Pakistan, who's built climate-friendly architectures, won a recent award, international award on this. And these are generally low-cost housings. So as I will say shortly when it comes to this, the worst thing that we could do with development for populations, urban and rural, was to introduce air conditioning and the concept of low ceilings that you could cool down, and then discover 40, 50 years later that the energy costs are unaffordable. and that solarization of everything is going to cost so much that eventually it's not going to be able to maintain air conditioning. Traditionally, if you go back several centuries, constructions in India and in Pakistan or other regions had tall ceilings, high ceilings, ventilators at the top so the hot air could be moved out, that you could operate. All of those wind catchers, all of those have been lost in this process of misplaced development and technologies that are not necessarily eco-friendly. But let's talk about the other structural innovations, things that have to do with many structural drivers that I alluded to as pre-existing social conditions. And of those, gender-related climate risks are many. And we can do something about this tomorrow if we wanted to. What do I mean by this? As I've mentioned already, in many low and middle-income countries, women bear the disproportionate risk of climate because of their work. They fetch water in many places. They are the main sources, women and young children, of bringing in firewood at times. And you can't do it when it's dark for a variety of reasons. Men can go to work when it's dark. They can work in the field and finish by the time it's midday. Women generally cannot. And this is one of the reasons why we find that across the world, Africa, Asia, Latin America, gender dimensions of climate change and heat risks are universal. Women bear the disproportionate risk. And in some countries, there are very limited adaptation or recognition. These impact things in terms of community support that's available to them or not. But we can change all of that by getting communities to recognize how important it is to support women, particularly at vulnerable time periods like pregnancy, and not exposing them in the middle of the day. And also creating climate-friendly health systems and health services. Now, what did COVID tell us? COVID taught us many lessons. One of those was there is nothing is cast in stone. And although there may be the recommendation by WHO for 8 antenatal care visits, there is nothing to say that you can't cluster those visits in a way that you provide enough commodities in every visit that she doesn't have to come back to get a supply every month. And also that instead of individual visits, you could do group visits. And you could arrange things in such a way that women can come at a time when they don't have to wait in line in heat in some of those services. So those innovations are within our grasp to do to make it possible for women to be less exposed to the environmental impact during the summers. And then, of course, there are things like facilities. We are working in rural Pakistan in one very simple intervention, that for things like bringing water, why can't men share that workload? And why can't they cluster their assistance in such a way that they could do this in the shortest period of time, particularly in the summer? So hence, stop the exposure rates of women disproportionately. These don't require rocket science. They require a body of work which is built on anthropology, understanding of the community, and working with civic society and funders to put those interventions in place. Outside of Canada, which has a very feminist, gender-sensitive policy, thankfully, there are very few funding bodies that are willing to support this kind of work on innovations to address the impact of climate change and disproportionate risks are women. This is something that has got to change globally. Okay, what can be done within the health sector? Now, traditionally, a lot of the stuff that we talk about in health sector is around what I've talked about, health finance, accessing this within the Green Climate Fund, which has been very, very little, addressing surveillance systems in relation to climate data and impact, changing health facilities. And I don't think that we are going to get solarization of all health facilities in low and middle income countries anytime soon, particularly with imported solar panels, which they are not going to be able to afford or to maintain. We've estimated in our own context of Pakistan that it will cost close to around $2 billion to replace all traditional energy system with solarization. So it might happen in the future, but it will take time. But importantly also, training a health workforce to be aware of the impacts of climate and resilience. And work on this, thankfully, has started. So I give credit to UNICEF for having produced the first document on looking at how do you protect children from heat stress in the peak of the summer in various contexts, urban, rural. And some governments for being ahead of the loop in terms of putting policies in there as to how you can do this at scale within your health system. So this is a recent document from the government of Bangladesh on looking at what can be done in terms of climate within their own primary and secondary health system. And some are still lagging behind. So the 1,300 deaths that took place in Hajj this last week should not have taken place given the amount of resources that were there and the awareness that needed to be in the frontline medics and response teams as to what to do when things happen. I personally think the explanations that we have got that these were undocumented people are nonsense. When you've got somebody who's collapsed in the field, the last thing you ask for is documentation. You respond. So the response services have got to be a lot more focused on what do you do for heat-related collapse and illnesses, and particularly in terms of educating people on heat adaptation. I think there is a huge amount of innovation needed around maternal health, and I've talked about some of those like group counseling, mobile health services, working with community health workers. And I want to show you one humble example from the field. We have something like 4 trials going on right now, but this one I particularly want to mention because this happened recently, and I never expected that this would have the impact that it did. So we've been working in rural Pakistan with actually colleagues here in Manitoba. I mean, Jamie Blanchard is a partner in our big effort, and I know that Zahid Mehman is participating in the project. This big Umeed & O project is in around 10 districts. And here is really what happened with floods and other disasters in terms of coverage of interventions across antenatal care period and delivery. On the orange line reflects what's happening in control areas, and we wanted to see what had happened in Sindh, which was affected by floods. So these 3 slides that I'll rapidly show you the impact of the floods on coverage of intervention. Universally, things went down in these districts in terms of coverage of antenatal care, and it was very comparable to what happened in COVID, whether or not they visited facilities and live births in facilities. Everything went down. So we were confronted with this reality in 2022 after the floods. What do you do in this population where health facilities are dysfunctional, where people don't have access to basic health services, and they're all sitting on the banks waiting for the waters to recede? So we thought that we would work with a program that we know best, which was the Lady Health Workers Program, Community Health Workers Program, and through a strategy of community engagement to see what could be done in terms of safe childbirth and delivery. And the intervention that we thought of was principally an enhanced birth kit being provided to these communities that we had pilot tested and actually implemented in some other districts in good times. So the idea here was to try and do this very quickly and in a manner that we could evaluate this. So this was a cluster randomized trial of enhanced kits versus regular kits. And the enhanced kits had 2 additional components added to it in addition to health workers educating communities. And that was giving cord chlorhexidine for cord care and skin care in a circumstance where extreme heat and exposures also led to an outbreak of all kinds of skin conditions in both adults and in children. So I never expected that this would have anything more than just the benefit of delivering these things. And we had a relatively smallish population. So use of chlorhexidine in the intervention clusters, obviously much, much higher for cord care. They continue to apply other things also. Oil massage in our environment is widely practiced. It's a social practice. But here you see that there were clear differences, and people used sunflower oil that was provided. And the outcomes really floored us, because if you look at the primary outcomes from this trial, we had a significant reduction in perinatal mortality, stillbirth rates, and also an impact on newborn mortality. We didn't quite reach significance, but it was in the right direction. And the big question asked is, we didn't put a single physician in the field. This was just community health workers distributing stuff to families and to care providers. How did this happen? And it happened because the community principally had more facility births and skilled birth attendance use. So advocacy, support, community education, does work in those settings. So that really has encouraged me a lot to now think of actually developing an integrated package that we can implement with community health workers at scale around maternal child health. We are working with support from Grand Challenges Canada on implementing a mental health intervention right now, which is a community-based study, again using the Lady Health Workers program, where for scientific evaluation, they have to go through a very stringent first level screening and then either counseling themselves or referral up the health chain. So there is a lot that can be done in those communities and can make a difference in the medium to short term while we wait for the COPs of the world to generate the impact that they are set up for. So let me close by just answering one question that I'm asked quite frequently. Now, I work in child survival. I've spent the last 3-4 decades on newborn survival, child survival, adolescent health, maternal health. And a lot of people ask me as to why did I pivot my own program to pick up the topic of climate change and health. And I can guarantee you that I did it much before the funding became available. We started work on this, some 4 or 5 years ago, even before, people picked it up. And the reason is very simple, that in terms of global challenges, this is the one existential challenge that we face for several generations to come. For every child born today, the likelihood of exposure to extreme heat events and to the consequences of extreme heat are odds of 4 to 5 compared to any generation before. So the world is changing so rapidly that if we don't act on this now, we will leave a world which is unlivable for many, particularly in low and middle income settings, where the impact of climate change is being grafted on top of existing polycrisis, climate conflict, cost of living, migration, and food insecurity. So the way forward is maybe not straightforward, but it's clear in the eyes of many people who work in global health. First of all, we need more knowledge evidence. Not research for research's sake, but research that's going to generate results very quickly in terms of data that will tell us much more evidence-informed information on causality, on attribution, and on the risk factors and pathophysiology. That will help us develop interventions which are a lot more targeted than we have right now. We need to include absolutely the measures that you see on the screen. Health equity issues, gender equity issues, issues that relate to intergenerational transfer, and mental health is something that does impact many of these things. So I do think it needs to be prioritized in terms of things that we need to do in our adaptation and resilience strategy. And cost. Just like we did in the Millennium Development Goal period, if we don't have an eye on solutions that are going to be low cost and effective, we will miss the boat here because many countries are not going to be able to implement. I went to a meeting last year. I didn't go to the meeting. I actually hosted the meeting where I invited people to come from, I will not name the region of World Health Organization, who came and he said, of course, the solution to extreme heat is air conditioning. Well, they came from a geography where they could potentially afford it, but I can tell you that even they won't be able to afford it down the road. So a lot more indigenous solutions that come from tacit knowledge, and that is probably just as relevant to Canada as it to any other geographies. And the last point is that we need all of this now. There is not a moment to waste. That this has a level of urgency around it, which is unprecedented in many of the global challenges that we have lived and worked through. And just like the world responded to COVID in some ways with an emergency response, I think global climate change, we need something like this. Thank you very much for your attention. And if there is time, I can answer questions.
Outstanding presentation. Thank you so much. We have time for questions. And after the questions, we have students that are going to have lunch with Zulfi. And also, I think before that, Peter will make some remarks. So questions, please. Yes.
Go ahead.
Thank you for a great presentation. You mentioned in one of your slides, it was about the study about homeless people in Boston and like we are talking about climate change in there. I was wondering how you differentiate the other factors, like for example, you're working, the people who are suffering from the outcome of climate change most of the time are from low income. So there are some other factors, for example, like the nutritional status, they are going into pregnancy. How do you differentiate that result from the?
So they didn't ascribe all the impacts to homelessness only, but it was a very important study that quantified the effects that were being observed in people who had other social limitations. So the point of that study, and I think a lot of that is described in the methodology and in the multivariate analysis that was done to control for various factors. Obviously, homeless people have many, many other challenges. But it does tell you that when you're looking for populations and subsets at risk of the adverse effects of environmental change and climate change, look for those factors because they may not be necessarily apparent because they could include within that a lot of exposures, extra exposures, and also other compounding factors that could compound the impact of those adverse effects. So I think the authors did go into their methodological rigor and their multivariate analysis controlling for other things. But it's one of the few studies. We don't have studies like that even in low middle income countries, outside of the one that I showed you from Karachi. It had Karachi slums identified. We don't have such studies yet outside of the one in India that I showed you as to which subgroups of people are more exposed and how are at greatest risk. And they could be the poor people, of course, but poverty in many places is ubiquitous. And poverty by itself does not give you enough targeting indicators as to who you should target, particularly when you are trying to address interventions.
Can we use the mic because we are streaming this so that people
Yeah. So
come down to the mic, please.
or I can repeat the questions.
Yes, that would be.
Yeah, sorry, I should have thought of that.
Shall
Please
I
go ahead.
You mentioned this about, is this on? About indigenous ways. And I've often heard this in my own studies and research about the indigenous structures as opposed to the settler structures. And I never really fully understand what they meant by indigenous structures, but I imagine that those structures dealt with heat dissipation. I certainly know that when it came to control of fires, the type of trees that were planted, having a zone around where you're actually living, those were indigenous practices way before the settlers ever came in. And I'm just wondering, from, say, an architect, like for building standards, what is in the indigenous structures that we can learn to rebuild our houses such that the housing is going to be dealing with the heat and not using air conditioners?
Well, that's a fantastic question. It's a very important question. It's a major focus of my program's work now. In fact, I've just appointed the first architect to my program in Karachi as a climate fellow. I think we need to understand a lot more of this. So like you're saying, indigenous populations differ from indigenous populations. I was in Western Australia just a few months ago evaluating the health program of their children's hospital. And we spoke about climate change and indigenous people living there, and I got an earful of the kind of things that they do in their own environment, ranging from building materials, traditional building materials, traditional roofing materials, and also work patterns, diets. What I did not know is that people change their diets. The Bedouins will tell you that they change their diets in the summer, principally to avoid dehydration, right? So a lot of that tacit knowledge is still there and needs to be captured rather than impose first world solutions on geographies which have a lot more knowledge of adaptation than we do. In my own rural work in Pakistan, one of the first things when we go and talk to communities is they tell us, but that's what we used to do. This is what used to happen, right? And we've lost the whole concept of wind catchers in many places because people were told this is a waste of time. Just reduce the ceiling height, and we reduce the ceiling heights in facility after facility after facility to principally air condition them. And now we can't air condition them. because there is no electricity, or nobody can afford electricity at that scale.
Thank you for a lovely talk. So for one of your slides, you had the description of the urban slums. I was just wondering that, like from my understanding, the primary reason urban slums exist in high population density countries like India and Pakistan is because of the limitation of the landmass. So like India is reaching 1.4 billion population with the 7th largest landmass. So I was wondering, what solutions do you recommend for getting rid of the urban slums? Because if like the high population and the restriction of landmass, which say a country like Canada doesn't face, so hence they're able to still maintain those high ceilings, have like bigger houses, which don't, which are kind of a luxury in
So I'll
other
likely
countries.
give you an oversimplistic answer, but the issues of urban slums in many countries are not just related to lack of land, is the propensity of people, particularly who are in informal work, of wanting to live close to where their employment is. There is generally ample space outside of cities. I mean, Karachi, for example, could expand all the way to Hyderabad. It's got 100 kilometers space in between, but people don't want to live outside. They want to live in the middle where they can get to work, etc. And also there is a land mafia that sells principally illegal land to many people over there. And over time, slums like Dharavi and others, will emerge. So I think there is a solution to this in terms of apportionment of land for adequate housing. And there are remarkable examples from South Asia, including, many large schemes where people have been able to get adequate housing with reasonable space in between, with reasonable construction patterns and materials, but through programs which are innovative. So, Khuda Ki Basti is one. And there are many other examples of this. So it's by no means a uniform thing. And there is generally a role of land mafia and land grabbers in this.
Thank you so much. It was an eye-opening talk as well as fascinating work. I was looking closely at some of the comorbidities associated with it. And dehydration, as you mentioned, a third of them had suffered from dehydration. And from data from our preterm children, we do know after postnatal birth that changes in electrolyte imbalance, fluid shifts, glucose, other things, do affect these periventricular germinal matrix and the head growth. And you showed very clearly there is that head growth restriction. I know it would be impossible to do imaging studies on them, but is there long-term data available to see how these children, in terms of survival, 5-year childhood survival, in terms of their functioning, or is that something that you would be interested in doing?
So Mubin, it's a great question, and I'm afraid there is no data on this yet because people have not done the studies. To answer your question, can you do imaging in utero and beyond? I mean, the answer is yes. There are studies being done with portable MRIs as we speak in many LMICs to look at drivers of brain development and growth. We are just beginning our journey on this. And as I said, it's just as important to understand the epidemiology as it is to understand the pathophysiology and mechanisms of how does heat impact things, because our solutions will be related to it. So yes, we're very happy to talk to you about what could be done in terms of understanding this a little better.
Hi, good afternoon. It's a really wonderful presentation. Allow me to introduce myself. I'm a student from Department of Health, Community Health Sciences. And I was born and raised in the Philippines, and I saw the Philippines as one of the developing countries which has experienced or is still experiencing malnutrition. And I have been involved with different nutrition programs from that country. Now, this is the first time that I have heard about stunting, the impact of climate change on stunting and wasting in a way that, a lot until now, nutrition programs focusing on stunting and wasting are being given or implemented. My question is, since there is a lack of information, specifically in the Philippines, do you think educating the communities as part of the intervention will help? And another question is, what do you think is the impact of the political system? Because that is, well, my work is on food security, and it's always associated with the decision makers and all those things. So thank you.
Well, thank you very much. If you have time, I'd be happy to discuss Philippines with you on the side. I mean, I know the country well. We've done some work there on anemia, and I'd be happy to talk about stunting in Philippines. Political economy of climate change, top of the list. Nothing will change until we have the political will to do something about it. This has not been on the agenda. Polycrisis and climate in the context of what I've spoken about of G7 and G20 for the last umpteen years. Ever since the Paris climate change agreement, the fight has only been on the big ticket items. How much money can we flow through to the big climate mitigation strategies, as really opposed to doing something about it in poor countries. The discussion on the loss and damage fund, again around climate disasters, not on adaptation and resilience, took years. It was finalized and agreed upon in COP27 in Sharm el-Sheikh. Last year and early this year, in the review of how much money has been paid into the loss and damage fund, it is not even 10% of what was agreed. So I agree with you. I think at this point in time, we need a lot more global dialogue around what needs to be done for climate change as a global community. And sadly, I don't see a lot of silver lining here because of the shift to the right in Europe and the imminent shift to the right south of our borders. I think political economy of climate change is going to take a big hit unless voices like yours, are heard and we do something about it as a global community.
Hi, thank you so much for the talk. I feel like completely throwing my thesis proposal out the window and focusing on this. It definitely set a sense of urgency, so thank you. My focus is on mental health and children's rights. And one of the things that really struck me is your focus on gender equity and women's rights around the issue of climate change. And yet, the burden of climate change will be borne by current children and future generations. And yet, children are rarely part of research and health research around climate change. So what do you see as health researchers today's responsibility to lift the voices of children and young people? As you said, they are leading us in the political changes. So what is our responsibility to future children? Thank you.
It's a great question. It's a very difficult one. I've just come from the Innocenti Center's meeting on child rights for children in the future, and my big pushback to them was that they didn't really have much on climate and environment in there as they should have. So within our existing statutes and human rights regulations, child rights regulations, we don't have enough on what is our right to the next generation, what is the right of the next generation, our responsibility to it. So my answer to this would be, I think we should start by listening to children, and we don't do enough of that. Making children, adolescents, young people part of our research projects and programs to identify what may be priority areas for them. I think if we hadn't done that, we would not have had mental health percolate up. Had we done that, we would not have seen the entire mental health crisis from school closures during COVID. So sometimes, a prepared mind is much better in terms of defining some of the research questions. So we should start by doing a good landscape analysis of what children are saying about this in terms of what they would like to see change. I think first time ever in the history of the world that children in many, many countries walked out of the school on one day in solidarity was around climate change, right? So you can't underestimate the impact of this. I mean, my children are grown up now, but I have grandchildren. My granddaughter is 7 almost, knows more about climate change than I would have done at the age of 17, actually. It's because they don't have a curriculum on it, but the children talk to each other. So I think we should listen more to children, and we should perhaps include them in designing interventions, just like we would include communities and women on designing interventions for women.
Thank you for this important talk. I had one question related to the fact that you mentioned at the end that the change is needed now, more research is needed now, but at the same time we see there is a lack of funding for several themes that you mentioned. How can you explain that, and how could we overcome the barriers that we are still facing to have more fundings for this kind of research? Thank you.
So, noise making. And I'm very pleased to say that over the last few years, and it's not just me making noise on this, it's the work of the Lancet Climate Countdown Commission and others, funding for climate change has exponentially grown, right? So what is needed now is not just at the aggregate funding envelope, is funding priority areas within climate. Everybody wants to fund stuff on climate, but there is a haphazard pattern of funding. And we've therefore, as my group has devoted the last 2 years on trying to do research prioritization on what are the gaps that need to be filled rather rapidly, what studies need to be done around epidemiology, what studies on basic sciences, mechanisms, pathophysiology, and what can be done around adaptation and resilience, low-cost solutions. So once we get consensus, that we'll have consensus by October. We hope to publish all of that. It's been a very involved exercise. I think it will be of great guidance to funders, governments, bilaterals, and importantly, researchers.
Thank you.
All right.
Thank you.
I think we have to stop it here because we have other engagement. Do you want to make an announcement before we thank you, before we say thank you to?
Thank you.
Thank you.
The two things I wanted to mention, one is the founder of the Friends of CIHR is Professor Abi Angel. He is at U of T now, but he was at the time of the founding chair of the Department of Medicine here at the University of Manitoba. So the second thing I wanted to mention is that we, in April, identified the 2024 Henry Friesen Prize awardee. His name is Professor Gordon Guyatt at the McMaster University. He's very famous for creating the concept of evidence-based medicine. So I'm hoping we'll be back in roughly a year with Gordon to give you another presentation. If you're interested, we actually have memberships available on our website, fcihr.ca. And all of the events are recorded there, and the talks and the documents and things. So thank you very much. It's been a real pleasure here. Thank you.
And thank you so much.